I think Jovia has joined.
Yes.
Jovia, can you hear us? Can you hear me? We need to test your microphone.
But if you look at scenario, I can hear you. Can you hear me, Sharon?
Yes, I can hear you.
Perfect.
Tend to
All right, so I think we are going to start as we wait for Joy. Let's wait for Joy for like 3 minutes. We see if she can join, then we can let people in.
Sharon, at what time do you want us to start? It's already 3:03. Catherine, are you letting in people?
Yes, Marian.
Okay. So probably we can start at 3 or 8. I don't know if that is okay. Maybe giving 4 to 5 minutes for you to let other people join, then we can start. I don't know if that is okay.
I need to be assigned as an interpreter for English French.
Hi, Iris. Let me get to that.
Thank
One
you very
moment.
much.
No, for me, no. Miriam, Miriam, do you need French? Connex, Cynthia.
No, I'm comfortable with English. I don't need an interpretation.
I'm also comfortable with English.
Allow me to start in the next 2 minutes.
Yes, Miriam.
Okay, let's wait for more people to join and then we can continue. So allow me to start the meeting because of time, and I wouldn't want us to have very limited time. So yeah, thank you so much for joining, and welcome to today's webinar on the topic of supporting children and young mothers living with HIV. I am really, really delighted to have you all join in this important and timely discussion. So even as we gather today, I believe that all of us are reminded of the significant challenges that are faced by millions of young women living with HIV and also children, and also in regards to the rise in the teenage pregnancies, both regionally and Africa and globally. So these people usually experience a amalgam of challenges, so which are ranging from limited health access to the overwhelming social stigma that are not just statistics. So these are also lived experiences that are affected by this population day in, day out. So with this webinar, we aim to raise awareness of the specific challenges that this population face and also explore the latest advancements and technologies in prevention, treatment, and care of HIV. So our discussion will also focus on practical strategies to reduce stigma and discrimination, also share best practices, and also highlight community-led initiatives that are also making a difference. So we will touch on various things that I believe all of us are really looking forward to this discussion. So with this webinar, we are bringing in experts of diverse backgrounds who are deeply committed in improving the lives of women and children living with HIV and also the affected ones. So my ask is for us to engage actively, both by raising our hands and also in the chat box. I am sure Sharon will really engage all of us and also give you guys time to ask in question and also make contribution for us to even take away any valuable insights that can help us in doing our advocacy work and for us to know how to better support and improve services for the community and specifically for children and women living with HIV in Kenya. So yeah, so not in Kenya, and globally. Thank you so much for being in this conversation and also for your commitment to this cause, also commitment for your time today. So let's really, after this, I'm really looking forward to us working together to create a more inclusive and supportive environment for children and young women living with HIV. And yes, I forgot to say my name. I am Miriam Ombugu from Kenya, and I am part of the Young Women, not Young Emerging Leaders under Y Plus Global. So yes, thank you so much for joining, even as I am seeing that more and more participants are coming in. So let's share this link. Let's encourage our networks to join in those different countries that you are coming from. We really want to have a movement of young people joining in this discussion for us to see how we can forge our way forward and also reduce infection among children, and also ensure that the children are living safely and the environment is more inclusive to them. So yes, let's encourage other people to join in. So from that, I think I have provided a good overview, a general overview of what is expected of us today. So let's engage, let's engage. We are here to talk, we are here to share insights, we are here to learn. So yeah, thank you. Sharon, I believe you can take in from there.
Thank you so much, Miriam. I'm happy to see everyone here. Thank you for that good overview. It has really enlightened the reason as to why we are all here, the reason as why we have gathered so many people from different diversities. And I'm happy that we are having a number and people are still coming on this call so that we can be able to look at how we can help children and young mothers living with HIV globally. Yeah, without wasting any time, I would love to introduce myself. My name is Sharon Nachito. I work with youth and adolescents representatives of Health Uganda, an organization that works basically for young people living with HIV in Uganda. And I'll be your moderator today. I'm happy to be here, and I would like to give the speakers time to introduce themselves in just a few minutes for us to be on time. Yeah, so we shall start with Jovia. You can introduce yourself, then we can hand it over to someone else. Jovia, over to you.
Thank you so much, Sharon. Good afternoon, everyone. My name is Mirembe Jovia Birungi. I'm a lawyer by profession, a human rights activist, and an activist for people living with HIV. I work with Center for Health, Human Rights, and Development. I am so happy to be here today. Over to you, Sharon.
Wow. Thank you so much, Jovia. I'm so happy to have a young lawyer and a mother living with HIV. I cannot wait to hear your perception, basically on your living experiences. So I am happy to be with you on this call, Jovia, and thanks for honoring our invitation. So I think we shall move to Cynthia. Cynthia, over to you.
Hi, good morning, good evening, everyone from wherever you are. Good afternoon. My name is Cynthia Buchira from Kenya. I'm a youth advocate. I'm a Nessa Richard youth advocate. I'm a pediatric advocate. I champion for ending pediatric HIV infections among children. I'm also an EPIC champion from Kenya. EPIC is a ending pediatric AIDS in children initiative that it is an advocacy initiative that is aiming to build a stronger partnership and harnessing advocacy messages to ensure the visibility of issues that are affecting HIV globally. Yes, thank you.
Thank you so much, my sister from Kenya, my neighbor. I'm happy to be with you on this call. Our other speaker is still having issues of connection. I think we shall move to Doctor. Doctor, please introduce yourself. Over to you.
Naria, you're on mute, Naria. You're on mute, Naria. Can't hear you.
Sorry, is it okay now?
Yes.
Yeah, okay, great. So my name is Naira Sarkisyan. Originally, I'm from Armenia. I'm a medical doctor working for the Global Center of UNAIDS. I have been working in the area of HIV for more than 30 years. So started working when there was no treatment, even testing was not in a high quality. So you may see that I'm a very committed person that continue working in this area till the end. I think in the end of AIDS, I'm very happy to be here joining this beautiful panel. Thank you for invitation. Over.
Thank you so much, Doctor. Before you go, I think we would really want to start with you. We will be so happy to have a summary of UNAIDS on how, especially the statistics of young people, children that are living with HIV. Please go on.
Please share the presentation. So I can start. Great. Okay, great. Thank you again. Thank you again for invitation. Really, it's very important initiative. I would like to start my presentation with some statistics, available data that UNAIDS is collecting with our global report, which was recently launched. So next slide, please. Across the globe, there are an estimated 1.37 million children under the age of 15 living with HIV. 86 of these children reside in sub-Saharan Africa, highlighting the regional disparity in the impact of HIV epidemic. In 2023 alone, 120,000 children were newly infected with HIV, mainly with mother-to-child transmission during pregnancy, delivery, or breastfeeding, an area where interventions can make a significant difference. Additionally, 1 in 3 infants born to pregnant women living with HIV miss out of a timely diagnosis. And sadly, in 2022, 76,000 children under the age of 15 lost their lives to AIDS-related causes globally. Overwhelming majority of these cases could be prevented. Next slide, please. We all know that globally, while all countries committed to reach global treatment target, these are 95 targets, which means 95% of people living with HIV should know their status. 95% of them should receive treatment, and of those who receive treatment, 95% of these people should have suppressed viral load. As you see, the slide shows stark differences globally between adults and children. Children aged from 0 to 14 years living with HIV remain considerably less likely than adults to be diagnosed. Only 57% of all children living with HIV globally are on antiretroviral therapy, compared to 77% of adults. In 2023, only 48% of children, compared to 73% of adults, had a suppressed viral load. Next slide, please. There is a substantial regional variation in progress towards 95 targets, especially when we're comparing children aged from 0 to 14 with adults ages starting from 15 years and older. In only 2 regions globally do children have greater progress towards free 95s when compared to adults. These are in South Asia and Eastern Europe and Central Asia. In all other regions, children have far lower progress on the free 95s compared to adults, with the greatest disparity being in West and Central Africa. Next slide, please. Children living with HIV are being left behind as considerable regional variation exists in knowledge of status and linkage to care in this population group. Even among those children who know their HIV status, concerning proportion of children are either those not on ART or on ART and not virally suppressed. Concerned efforts really are needed to ensure that these children are not being left behind and being linked to HIV care. Early diagnosis and timely initiation of treatment are particularly critical in case of infants. I will tell about the WHO recommendation regarding the testing in a few minutes. Countries have made some progress in expanding access to early infant HIV services, but testing rates are still low. WHO revised treatment and testing guidelines recommend that infants, if HIV exposed, should be tested by 4 to 6 weeks and 9 months age using virologic assay and when the child stopped breastfeeding with a rapid antibody test. Those found positive should immediately start antiretroviral therapy upon diagnosis. With progress in expanding access to early infant testing services and antiretroviral treatment for children, we are seeing that these children surviving and aging out of childhood into adolescence. Next slides, please. According to the latest UNAIDS report, last year, 44% of all new infections worldwide were among women and girls of all ages. The situation is particularly stark in sub-Saharan Africa, where 62% of all new infections in 2023 occurred among women and girls. Every week in 2023, 4,000 adolescent girls and young women aged from 15 to 24 were newly infected with HIV globally. 3,100 of these new infections occurred in sub-Saharan Africa. We also face ongoing issues with high vertical transmission rate in some countries. In countries like Nigeria and the Democratic Republic of the Congo, vertical transmission rate exceeds 20%, underscoring the need for more robust prevention strategies. These figures illustrate that pressing need for continued focus on gender-responsive strategies in our efforts to combat HIV, particularly in regions and populations that are most at risk. As we reflect the challenges faced by children and young mothers living with HIV, it's also essential to acknowledge significant progress we have made recent years. First, we can celebrate that 82% of pregnant women living with HIV are now accessing antiretroviral therapy. This is a crucial step in preventing mother-to-child transmission and ensuring healthier outcomes for both mothers and their babies. Moreover, since 2010, we have witnessed 58% of decline in new HIV infections among children. This is a remarkable achievement that highlights the success of prevention strategies and global commitment to ending pediatric HIV. Additionally, there has been 49% decline in new infections among adolescent girls and young women during the same period. This progress is really particularly encouraging the effectiveness of targeted interventions and educational programs aimed at young women who are among the most vulnerable groups. This is a very interesting slide. It shows it's capturing AIDS epidemic over the past 32 years and shows us the counterfactual what would have happened if we hadn't scaled up antiretroviral therapy, how many more deaths we would have had. But focus on the blue line. This is what we have seen in the decrease of AIDS-related deaths. And many of us were there through those years, and we saw this happen with our own eyes. And comparing that to the orange line, I even don't want to, to imagine how the world, what will be happen in our world. Now I want to focus on other issues. Please, next slide. Children have historically been left behind adults when a new optimal generic medicine is developed and generated. Children often wait decades until effective age-appropriate formulations of the same medication become available. WHO advised that immediate antiretroviral therapy is crucial if HIV infection is detected in any child under the age of 5 years. Dolutegravir-based HIV treatment regimens are now recommended by WHO for children living with HIV whose weight is a minimum 3 kilos and at least a child is 4 weeks of age. When pediatric dolutegravir containing medicine become available, it was a really game changer. Over the years, we have seen a significant increase in the adoption of dolutegravir as part of preferred first and second line antiretroviral therapy when it comes to children containing regimen. It also made significant strides. So now many countries, it's like a number of countries are increasing who are moving from treatment regimens containing non-nucleoside reverse transcriptase inhibitor and the lopinavir ritonavir to pediatric dolutegravir. Next slide, please. Here is this slide is for those who are not very much informed, very much aware about what is the difference between regimens, ARV drugs, ARV formulation. This is just for information and just a reminder for those who are well familiar with. ART means 3 different antiretrovirals given together. Antiretroviral is just one drug in a regimen. These are abacavir, lamivudine, and lopinavir ritonavir. An antiretroviral may come in different forms, but it is the same drug. So it could be in liquid, tablets, or pellets and granules. Next slide, please. So here is the list of available products, pediatric antiretrovirals formulations. These are, you see how long is this list. This is more than 70 products and counting available now in the world. Next slide, please. Pediatric antiretroviral therapy is now fully harmonized across populations and aligned with adults' standards of care. Pediatric abacavir, lamivudine, dolutegravir, this is pediatric ILD fixed dose combination, is something new which become available recently, and this is recommended. This is triple fixed dose combination, which is free medicine in one tablet, which easy to take. And you may see in blue table that number of tablets per day, dosage, based on the weight of a child. So this is very important information, and more details you will see in the presentation that will be, I hope, will be available online. Next slide, please. By the way, generic application of this medication is sent to WHO pre-qualification program, so generic ones will be available soon. Now I would like to share with you the status of WHO HIV policy adoption and implementation status in countries globally. In 69 countries, these are among reported number of reported countries was 114. Dolutegravir is now as a preferred treatment initiation option for infants and children. Within this group, 33% have adopted dolutegravir, especially for children with weight more than 20 kilos, while majority recommend dolutegravir for all children older than 4 weeks with weight more than 3 kilos. This widespread adoption of dolutegravir highlights its effectiveness and the global commitment to improving HIV treatment outcomes across all the ages. Next slide, please. Oh, no, it is here. The WHO recommend using dual HIV and syphilis rapid diagnostic tests for pregnant women in antenatal care and for key populations. According to the data available, countries, 77 6 countries have already adopted this policy and included in their national policies. More than half of these countries adopted it not only for pregnant women, but also for key populations. Next slide, please. WHO is also recommending routine viral load monitoring to see the treatment effectiveness. And according to the available data, this recommendation has been implemented countrywide in only 74% countries, with number of 98 countries globally. 98 countries, low and middle income countries. WHO provides also guidance to eliminate the vertical transmission of HIV, hepatitis, and syphilis of all reporting countries. 74 has already national plans for eliminating the vertical transmission for both HIV and syphilis. And this strategy is already included in the national strategy. WHO is also recommending monitoring of HIV resistance to dolutegravir. According to the latest research that I found, as of July last year, only 6 countries have implemented survey on acquired HIV drug resistance among children and adolescents receiving dolutegravir-based antiretroviral therapy. And only 1 survey is ongoing, and in 1 country, and 40 countries are planning to implement that. Next slide, please. Globally, the global community is committed to eliminating mother-to-child transmission of HIV, syphilis, and hepatitis as a public health priority. Through triple EMTCT, Eliminating Mother-to-Child Transmission Initiative, and WHO is conducting validation, announced this validation initiative, and each country who is doing well may apply to WHO for validation. This is the list of countries who already validated HIV only or syphilis only or both of them, and some of them are just in the process of elimination. So you see that the process is started in 2015 with Cuba, then joined it Armenia, Belarus, Moldova, and Thailand, but still the number of countries are not very big. Next slide, please. The global community has been talking about children being left behind in the AIDS response for a long time, for years. But now we are seeing strong political commitment to this agenda to the Global Alliance to End AIDS in Children by 2030. This initiative is UNAIDS is leading, and fully involved in this initiative. Represents a unified and comprehensive efforts bringing together government, international organizations, civil society, and affected communities. The Alliance aims to ensure that no child is left behind by scaling up prevention efforts, expanding access to HIV treatment, addressing social and structural barriers that impede progress. Through coordinated actions and shared responsibility, the Global Alliance seeks to close the gap in care and achieve ambitious goal of ending AIDS in children by 2030. This renewed focus and collaborative approach give us hope that we can finally turn the tide and secure a healthier, HIV-free future for all children. I have put here the link to the latest report to this initiative, and the latest report of implementation of this initiative is available, so you can go there and get more details on the progress made. Next slide, please. As I conclude my presentation, I would like to echo the words of our UNAIDS Executive Director. We can end AIDS in children. With the medicine and science available, we can ensure that all babies are born and remain HIV-free, and that all children are living with HIV, get on and stay on treatment. I think with this positive note, I will end. Next slide, please. So here is my email. And if you want to get more information, to get clarification, to get some publications, please do not hesitate to contact me. I'm very responsive, so you may contact me anytime. Thank you, and over.
Wow, thank you so much, Doctor. We are so privileged to have such information. I know the young people that are online right now that are with us on this call, they are really having the best information that they need to know before we go into advocate more for ending HIV by 2030. Thank you so much.
With pleasure.
I would like right now to call in the next speaker before, yeah. Yes, Joy. I would like to bring in Joy. She did not have enough time to introduce herself. Joy, would you please come in now and introduce yourself in the shortest minutes as we go ahead? Joy.
Hi, hello, can you hear me? Can you hear me?
Yes, you're loud and clear.
Okay, good day, everyone. My name is Joy Oboyi, and I'm a sexual reproductive health and rights activist in Nigeria, and I'm focused on adolescent girls and women's rights, ensuring they have access to comprehensive healthcare services. Thank you.
Wow, we are happy to be with you, Joy. And we cannot wait to hear from you. So Joy, before you go, please allow me give you time to speak. I really have just one question for you, and it goes by, what are some of the key barriers to accessing maternal healthcare services and social challenges that women living with HIV face? And how can we really address these challenges? Over to you, Joy.
Hello, so can you still hear me? I just want to confirm that you can hear me.
Loud and clear, Joy.
Okay, so very quickly, because my network is a bit messy, I know Doc has given an overview from her presentation. So for me, number one will be the issues around awareness, cultural, religious, and societal beliefs of HIV, which still remains a major challenge globally. And secondly, it's around stigma and discrimination against women living with HIV. This hinders women's access to adherence of services, especially as regards to preventing new HIV infections amongst children and ensuring that their health is also being protected. Hello, can you hear me? I just want to be sure.
Yes, Joy.
Okay, that's fine. And so thirdly, we have the issues around violence and abuse, which limits women's accessing services to prevent new HIV infections in children, as well as protecting their health, yeah. And also the issues around traditional gender roles that is related to maternal health is also a barrier, which limits women access to comprehensive healthcare services as well as adherence. We know we're in a society where the patriarchy is high, and then a lot of times women do not have enough opportunities to make decisions about their body autonomy and then having to access services because sometimes their spouse has to make decisions for them, yeah? Hello, can you still hear me?
Yes, Joy, please go ahead.
Hello? Okay, that's fine. So fifth, we have the issues around lack of awareness and mistrust of healthcare workers and healthcare providers is also a major barrier to women accessing comprehensive healthcare services, especially as regards coping the issues of new HIV infections in children. And lastly, the availability and accessibility to healthcare centers is also an issue because a lot of times you have women complaining about or the distance to healthcare facilities is an issue, thereby causing the accessibility to services limited for women and girls. So very quickly, talking about how to address this is first understanding and adequately responding to gender-related and cultural barriers. to maximize access and adherence to comprehensive healthcare services to prevent new infections among children. Again, it's also important that we practice like a multifaceted approach, which includes healthcare systems reform, community engagement, legal practice, engagement of legal practitioners, and also empowerment of initiatives that promotes women's health. And then in a nutshell, there's need for collaboration from both NGOs, government, healthcare providers to create an enabling environment for women living with HIV to access services without fear of stigma or discrimination. Yeah, so that's from my own end.
Thank you so much,
Hello.
Joy. Before you go, I would love to give you this other question that you will answer with another speaker, Cynthia. Is that how can psychosocial support programs be tailored, including the frequency to meet the specific needs of mothers and children affected by HIV/AIDS? Over to you, and Cynthia.
Okay.
Sharon, before she goes on, Joy, can you mute your mic?
Yes. Miriam?
I was asking Joy to mute her mic because of the background noise so that we can hear Cynthia clearly.
Okay. Cynthia, can you please go on as Joy joins you?
Okay, so thank you. Thank you for this opportunity. And just to feed into your question on how can psychosocial support programs be tailored, including the frequency to meet the specific needs of mothers and children affected by HIV. I can say that for psychosocial support programs can be tailored to meet the specific needs of mothers and children affected by HIV through conducting structured community dialogues to understand the unique needs of each mother and child, including their, like these will include their psychological, social, and medical needs. And these sessions, they need to be consistent. Let's say like they have to be like maybe, for example, monthly sessions, monthly psychosocial sessions. And these support groups or these psychosocial support groups or support programs will be providing a safe space where mothers and children can share their experiences, you know, the power of storytelling. And this one will lead to building a community, like a community of understanding, or rather a community where there is trust among these mothers and children who are affected by HIV. And we also need to engage or involve the caregivers of those children who are infected or affected by HIV in the support process, like to create a supportive environment, home environment for the young ones, or rather for the children, so that we can promote treatment adherence and to also strengthen the parent-child relationship. Thank you.
All right. Thank you so much, Cynthia. I think that is very, very important to know what the community really need so that we can be able to tackle exactly what they need. And I guess helping them psychologically is really, really very important. So can Joy, Joy, you can join now, please. Joy, over to you. Joy, are you there? Okay. As we wait for Joy, I think we are going to go back to Cynthia. Cynthia, how can we effectively challenge and combat stigma and discrimination against mothers and children living with HIV? Over to you, Cynthia.
Okay, so we can effectively challenge and combat stigma and discrimination against mothers and children living with HIV through awareness creation, where we conduct campaigns and community outreaches. This is to educate and educate communities about HIV transmission, like how HIV is transmitted, and and also about prevention and treatment, and also like talk about the reality of living with HIV, so that we can be able to demystify the myths and misconceptions around HIV transmission, HIV prevention, and HIV treatment, so that we can reduce the stigma that comes with fear. Because most of the time people or the community stigmatizes people living with HIV because of lack of information or inadequate information, and this just leads to the to the natural fear of HIV virus itself. So if we can have this awareness, especially in the community, to demystify all these myths and misconceptions around HIV transmission and treatment, this will go a long way. And we also need to integrate information on HIV in school programs, so that we can foster an understanding and the science growth around HIV. We all know the science around HIV has really evolved, and a lot has changed when it comes to HIV treatment, and also HIV prevention. We can also create awareness on, we really need to create awareness on prevention of mother-to-child transmission in the community or to the community, so that we can make people understand that women living with HIV can also give birth to HIV-negative babies. We really don't have to wait until someone is pregnant before we share this information with them, this information on prevention of mother-to-child transmission. Because from where I'm sitting, I personally feel like we are a little bit selfish with the PMTCT information, and that is why like children born or children who are affected or born of HIV positive mothers will always face stigma and discrimination in the community, just because their parents are HIV positive, because there's still no clear understanding in the community. Like the community does not really understand or does not believe that a woman living positively can give birth to a HIV negative baby. So we really need to put this information on PMTCT out there for the community to understand, for it to sink in, for them to know that just because a woman is living positively, she'll automatically give birth to a HIV positive baby, or by just interacting with the people in the community, they will get infected. No, we also need to pass information around on U is equals to U, like undetectable is equals to untransmittable. We need to disseminate this information there. We need to create awareness in the community around this, so that that will help. Us to curb this stigma and discrimination.
Thank you so much, Cynthia. I think this is really, really so insightful. As young people, we are facing a lot of discrimination and stigma when it comes to especially when we have disclosed our status. It is really, really very bad, and I really, really urge every advocate here to really make sure that we pass on this information to the people. We pass on this information to the young people, especially in rural areas, and also the key populations, we should also look at the young key populations because they are really facing more stigma than other people. Thank you so much, Cynthia, for that insightful presentation. Before we go any further, I'd like to introduce or to give platform to Jovia. Jovia, I would like to ask you this question. What policy changes are needed to improve the overall well-being of families affected by HIV/AIDS, and how can we advocate or work towards implementing these changes? Jovia, over to you.
Thank you so much, Sharon. Once again, my name is Mirembe Jovia Virunji, and I'm in Uganda.
Nothing useful to add, guys.
I work with the Center for Health, Human Rights
You
and
guys are speaking
Development.
everything I want to say, so let me save time.
Yeah, so diving into your question, into the question, Sharon, I would like to give a brief about how a policy and law looks like in Uganda as of now. So recently, Uganda passed the HIV and AIDS Prevention and Control Act. And this act is specifically supposed to prohibit discrimination against individuals living with HIV in various settings, including hospitals, employment, at school, and public services. However, the law has about 2 or 3 clauses that are problematic to people living with HIV. One, this act actually provides for disclosure or release of HIV test results. And it specifically says that a health worker has a right to release your HIV positive results to any person with whom an HIV infected person is in close or continuous contact, including a sexual partner, if the nature of contact, in the opinion of the medical practitioner, poses a clear and present danger. So this is problematic because Jovia can go to a health facility and test positive, and the health worker has a right to disclose my status without even my consent, which is really unconstitutional and takes away the right to privacy of the individuals. The other problem with this act is that it provides that a person who attempts to transmit HIV to another person commits a felony. And our question as civil society has always been, what is an attempt? Well, how exactly does court look at attempt? And then we also have the most problematic of all, intentional transmission of HIV here. They say that a person who willfully and intentionally transmits HIV to another person commits an offense. So that means ideally that if Jovia is HIV positive and she is aware of her HIV status and infects, for example, Peter, Peter can actually go and report Jovia. What this means now is that we are going to have children reporting their mothers, because now a mother is aware of her HIV positive status, she gets pregnant and gives birth to an HIV positive baby. So when these children grow up and find this law, it is going to be used to criminalize mothers. Also, if I'm in a relationship with Peter, who I even disclosed my status to, and then things don't turn out right, Peter can actually go and report. We have actually had a number of cases where people have been arrested and imprisoned under this act. And by the time you come out, because police in Uganda does not really investigate before arrest, they arrest you and then investigate after. So what that means is that if somebody goes and reports Jovia infected with HIV, they don't even test Jovia. They don't even test you, the person who has reported. They just get Jovia and put her behind bars. So if Jovia is a poor woman who doesn't even know what the law says, who doesn't even know where to find lawyers, Jovia is going to rot in jail. So these are some of the a few policies and laws that are really problematic to us. However, not all is bad. We have a few progressive policies in place that really speak to human rights protections. One, we have the National HIV Testing Services Policy. This policy outlines guidelines for HIV testing in Uganda, including the need to get informed consent. There are so many cases where we have had people actually tested for HIV without their consent. This is mainly with housekeepers. For example, I get a housekeeper and I take her to a hospital. She doesn't even know what we are doing there. And then I just tell the doctor, test her. Results are given to me, and then I fire her when she's positive. So this particular policy ensures that there is informed consent before HIV testing is done. We also have the National HIV Strategic Plan. This one is a very important one because it sets out the country's priorities and strategies for preventing HIV and also addressing social and economic barriers of HIV. Actually, this one is a very important policy as it directly speaks to HIV programming and it provides comprehensive solutions. This one deals with mental health. We have a provision for mental health under this policy. Here we talk about SRHR, the need for people living with HIV to have comprehensive access to SRHR. Let me be able to walk into a health facility and at clinic as a pregnant mother, be able to get antenatal there, get ARVs there, and if I'm not pregnant, be able to get family planning in the same place, do cervical cancer in the same place, and perhaps have psychosocial support in that same place, other than having an art facility, which just gives medicine minus all these other services. So we also have the anti-stigma and discrimination bill. This one criminalizes discrimination against people living with HIV. Unfortunately, we are still a long way from ending stigma against people living with HIV, but at least there is a policy. Yeah? We also have the Employment Act. Now, this law prohibits discrimination in the workplace. So people are not supposed to be discriminated in their workplaces because of their HIV status. So Jovia cannot lose a job just because she's HIV positive, but we have seen incidences where people living with HIV are actually denied some jobs because of their HIV status, and realize that this is a big advocacy issue that all CSOs in different countries need to take up. For example, I don't know about other countries, but in Uganda, you cannot move out of the country to go maybe to United Arab Emirates to work if you're HIV positive. I'm also aware that you cannot join the army if you're HIV positive. So this is really discriminatory, even if the Employment Act provides other ways. We also have the education policy. This one provides for non-discrimination for children living with HIV. So in the past, parents would not take their children to school just because they were born with HIV, with the idea that they are going to die anyway. But we have seen science revolve. People living with HIV have grown up to 50 years on medication and they are okay. So now we are saying that even children born with HIV, unfortunately born with HIV, in this day and era have a right to education so that they can achieve their potential. So all these laws and policies are meant to protect the rights of people living with HIV, to promote access to healthcare services. We should be able to actually get medicines when we want them. And all these policies, if implemented, are really good resources and good for us to ensure that there is respect for human rights for people living with HIV. So what needs to be done? Here we can ask advocates and organizations to monitor implementation of the laws. So one problem in Uganda we have is, we have a good thing is that we have so many policies, so many laws. Everything has a law, has a policy, everything has a guideline, but our major weakness is in implementation. I don't know how it is in other countries, but we need to follow up as civil society organizations, as advocates and activists. We need to ensure that we hold our governments accountable so that they can actually ensure that implementation of these laws is done. Because if we have implementation in place, that means that we are going to see an end to new HIV infections, because mothers can easily access treatment. Mothers are not scared to go to a health facility because of poor laws. Because if a law says that a person can disclose my status to any other person, I'm not going to go and test. I will shy away. And if I don't test and I get pregnant and I'm not on medication, of course, we are going to have a baby who is born positive. So if we can have advocates follow up our implementation of these laws, it would be really nice. We also need to have improved access to healthcare. Yes, let us have healthcare services that are available. Let the hospitals, let the art facilities actually be available, but then let them also be accessible. Because you cannot have one art facility in a whole district. There is no accessibility there. If I need transport to get to a health facility, that is not accessibility. I should be able to easily get to a health facility and get services that I need. They should also be affordable. Yeah, there are some people who actually even just, of course, ARVs are supposed to be free, but in Uganda, things are not as they are supposed to be. But we also need some other essential medicines apart from ARVs that are bought. Let these medicines also be affordable, and let all these services be quality services. We cannot have a health facility without doctors. We cannot have a health facility with doctors but no medicines. We can't have a health facility with medicine and no doctors, yeah? So it's really comprehensive and it's wholesome. We need to look at it wholesomely. Then we also need to ensure that advocacy for prevention of HIV actually continues. In this day, there are some people who actually do not believe that a person living with HIV can look healthy. So somebody approaches you and they ask, and you tell them your status, and they're like, HIV didn't come to kill animals, yeah? And people take it as a joke, especially the youth, and it is not joke, it is not a game. So we need to ensure that we emphasize the need for protection. Let people take charge of their lives. Let us not put the burden of protecting people from HIV on the HIV positive people, because the law that I cited earlier actually assumes that HIV positive person must ensure that they protect the HIV negative person, which is really unfair. All of us should be able to take charge and control of our lives. We also need to enhance support for orphans and vulnerable children. So in most cases, we have seen orphans and vulnerable children fail to attain the last 95. They are not suppressed. They are on treatment. Those who are lucky get on treatment. Those who are not lucky because of lack of support, they do not even get to the hospitals. And we've seen them die, lose their lives, or even get to the AIDS state because of lack of support. So we should encourage supporters of orphans to ensure that they actually give them attention that they need to ensure that they adhere and have suppressed viral loads. We also need to improve on community-based care and support. Communities need to be there for each other. Yeah, you cannot see a person living with HIV and you could do something to help and you don't. Let us have a bit of humanity. But then also, we can ensure that there's comprehensive healthcare coverage across the countries. Let's ensure that we hold our duty bearers and our policymakers accountable, ensure we have health facilities. We also need to ensure that we have streamlined employment and economic support, because it is a silent killer for a person living with HIV who is not financially stable. You have medicines to take, you have no food, you have no shelter, you have children to look after, and you have no hope at all. So we might need to invest more in economic activities, in economic empowerment for people living with HIV, especially women and girls. We also need to raise awareness and advocate for policies that actually promote awareness about HIV to reduce stigma and discrimination. But most importantly, and lastly, is the need to ensure that there is legal protections. We cannot have laws that make people shy away from accessing treatment. I keep talking about the different laws like the HIV Prevention and Control Act and the Anti-Homosexuality Act, and people say that you are promoting homosexuality. The issue here is people living with HIV exist in all diversities. And our point has always been ensure that there is access to medicines for people living with HIV, whether they are gay, whether they are lesbians, whether they are heterosexual or bisexual. Our constitutions in all our countries provide for a right to health for all persons, and they don't break them down. So all persons will mean that we advocate for access to services for people to ensure that there is limited spread of new HIV infections, and then we can ultimately end HIV by 2030. Over to you, Sharon.
Thank you so much, Jovia. I really have nothing to add and nothing to reduce. As a lawyer and as a young mother living with HIV and as an advocate, you have really given us all corners what we are supposed to do. You have showed us the policies and what we don't have as advocates. Thank you so much, Jovia. Yeah, for the interest of time, we have few minutes to go. I would want us to go into our Q&A session, and I would want to push this to Marianne to take us through the Q&A session. Over to you, Marianne.
Really enjoying the discussions here, and I'm happy that we've highlighted the major challenges, also providing solutions to our issues. And even for Uganda, the policy environment, it's really unfortunate that even for us as Kenyans, we are experiencing this same. But going on to my task, so I will first request if there's anyone who has a question or comment, please, you can raise your hand. We'd really like to hear your voice. We'd really like to get your insights. So in the meantime, I will read the questions that has been asked in the chat box. So there's Domitila Nyango. Hi, Domitila. Greetings once more. Young children and adolescents really need psychosocial support. And from a group, these children talk and even discuss how they're being sidelined when it comes to their treatment. A 9-year-old asked me, why should my mom be informed about changing my drugs instead of me who takes the drugs being informed first? Wow. Wow, this is a really good question that maybe I can ask Jovia to respond, because it's something that I am happy that even a 9-year-old is really empowered to ask such a question. So yeah, Jovia, if you can respond, that will be great.
Thank you so much, Marianne. Can I beg your pardon on the question?
Okay, no worries. Let me read for you once again. Domitila has said, young children and adolescents really need psychosocial support, and from a group, these children talk and even discuss how they're being sidelined when it comes to their treatment. So now this is the thing. A 9-year-old asked me, why should my mom be informed about changing my drugs instead of me who takes the drugs being informed first? This is not a question precisely, but what would you say around that statement?
Okay, I believe that it is important if the child is of age and they've been told why they are taking the medication and they are taking their medication properly, then they should be informed of any development that occurs to their medication. Of course, in a way, in a language that they can understand as children. If a 7-year-old has been told that, look, here you're taking medicine because you have HIV and A, B, C, and D. When time comes and this child is used to taking 2 tablets, and now you want to change the child to 1 tablet, let them know why are we changing you to 1 tablet and what are the possible side effects, because now this child can actually understand, and it would actually help them to better adhere to their treatment and take control of their lives. So I believe at any stage a child is able to understand, let them be directly involved in their medication and treatment. Thank you, Marianne.
Really, thank you so much, Jovia. That was really good. Agnes Okosa, she has emphasized on what Cynthia had mentioned about community engagement on HIV, mother-to-child transmission. So I believe this is something that is ongoing, but we still need such engagements to be strengthened in the community. There is Mina Kakaya, a public health campaign. So yeah, that is really true. In the meantime, I don't know if none has raised their hand. Let me continue. So Domitila has again said community members should have dialogues to understand the implications of stigma and discrimination. As stakeholders, anytime we get a platform, let's finish with the information about ending HIV stigma, even in the forum, even if the forum isn't health related. That's good. That's good. Let's use any chance that we get to provide information on HIV generally and also stigma and discrimination. There is Hashim Yusuf, very insightful topic. Yeah, thank you. I'm happy that you're learning a lot. There's okay. So there's Mina Kakaya. So I think I will still throw the ball to Jovia. How to share good practices or policies globally. I don't know if Mina, you can be able to unmute your mic and provide clarity to your question so that Jovia can provide solutions in clarity.
Everyone, can you hear me? Can you hear me?
Jovia, please mute your mic. Oh, thank you. Thank you, Mina. You can go on.
Yeah, so I'm sorry, I'm speaking from London. It was just kind of a thought around what Cynthia and Jovia was talking about around, good practices and how within Africa or globally, obviously we have the UN AIDS vision and policy framework, and how much of that is being shared amongst NGOs at the grassroots level, but also at the top, and how is it actually done? I mean, are people sharing some of the things that we're sharing here? Because some of the issues are very similar actually in the UK as well, and it's just really more about, is there a forum or a space where people can tap into resources about what countries doing what around developing good practices or activism or whatever that might look like, around employment law, human rights laws, around all of that as it was shared really. So it was just about really think about, is there a central space where people can access those resources around good practice? Thank you.
Thank you as well, Mina, for answering, for asking your question. So, Jovia, I don't know whether you can please go on and respond to Mina.
Thank you so much.
Okay.
Yeah, thank you so much. I believe that we need to continue doing advocacy because actually also read. We need to empower young people living with HIV to read. All these laws are in our online, they are everywhere, but people are not aware because they don't read. But also what we do is we have community engagements. When we meet health workers, we talk to them about the laws on non-discrimination. When we are having young people in a room or in a meeting, we talk about laws. Like we use every opportunity available to share these laws and practices. However, what I clearly do not understand right now is how we can share this globally. And I believe we can use global platforms like this one. I mentioned a law, and then you can go and check with your country and see. We hold our ministries of health accountable, and they show us these laws because they are actually there. We just need to be a bit more proactive. Over to you, Marianne, if somebody has anything else to add.
Awesome. Thank you so much. Thank you so much. Naira has sent a message on the chat box. So, Mina, you can just click in on the link and you can provide information and also read through whatever you need has done. So there's some good question coming in from the chat box. Awesome. You're welcome, Mina. Kevin has asked a very good question. What can we do so that we can reduce stigma to young people living with HIV? Because here is our sickness came from. So I think what Kevin is trying to mean is stigma. The people living with HIV is of course attached to stigma and discrimination. So how can we reduce stigma and discrimination for people living with HIV? So I will direct this question to Cynthia Bushira. So please help Baraza understand how we can reduce stigma in our community. Hi, Yun. Please mute your mic so that you can allow Cynthia to go on, and then you can go on if you're willing to speak.
Hello. Can I ask a question, please?
Just a minute. I'm going to give you a chance just right now. So I don't know whether Cynthia is still around or Joy. Is Joy around? Cynthia? Okay. So if they're not around, I've seen Liz. You have raised your hand. Let me allow Liz, and then Mohammed, you can do second.
Okay.
Hello.
Hi, Liz. How are you?
I'm good. Thank you, Marianne and team, for hosting this meeting. I think for me, I also came in late. So in case this was discussed, maybe you can just pass it, yeah? So I'd just like to add on the term of inclusion, making sure that young people in all our diversity are included in the advocacy towards ending AIDS, and in this context, specifically about empowering children and young mothers living with HIV. So I don't know if it has been discussed, and I would like to pose this question to the person from UNAIDS. I would like to know if we have any reading materials that are specifically targeted to people with disability or young people with disability, and if not, maybe a recommendation when we develop materials and other advocacy tools. How about we consider people who have, let's say, for example, people who cannot read or people who cannot hear? What do we have for them? Do we have materials that are like made in visuals for people who, for the deaf community to be able to see and interact? And then next, what is our plan for young people in rural settings, or maybe young people young mothers, let me be specific, young mothers who don't have access to internet, Wi-Fi, smartphones to get access to such informations, because one of the number one barriers in accessing services is the lack of information. So if you don't have information about the existence maybe of PrEP or the existence of medication that can prevent HIV transmission from mother to child, or even the new development in science, that is U equals U, then you are not able also to ask for these services. So what do we have in plan for this particular typology? And how are we even trying to bring them on board in our advocacy? And also also how do we plan to bring them on board in ensuring that they are leading in interventions that are addressing their needs as young mothers from rural areas? Thank you, and over to you, Marianne.
Thank you so much, Liz. That was a line of conversation of questions, but it's good that you've asked that question. So before I allow someone else to go, so Mohammed, please ask your question, and then all of the questions can be answered by our panelists afterwards.
Okay, good afternoon, all. And my question is, people who are living with HIV and AIDS in community are facing, and it's come to my knowledge when I was working in a community project with my organizations, whereas and I visit a community, whereas let me say 30% of the young ladies who are living in that community are HIV patients, and some of them are afraid of coming out to speak and to see how best they can find ways to cure their situation within that particular time. So, and I and my team decided to engage the community leaders who are living there in that particular community to see how best we can a platform, counsel them and speak what exactly they are going to, what are some of the stigma they are going to, because some of these girls who are living in that particular community are facing challenges because some of their friends are not coming close to them because of they understand that they have this particular thing. So they are trying to prevent themselves in their own ways. And my question is, how can we engage community leaders in educating them on how to address HIV and AIDS in community level by encouraging these victims who have these particular things, who have these particular things for them to fit in society, and also encouraging them for them to belong among others, and also create an prevention opportunity for them to have access to medications, because in some parts in Sierra Leone, but especially when you look at the provinces, and we as an organizations, we are just going there working in different type of projects. But what are some of the mechanisms we put in place to see how best we can able to tackle some of these issues? Not all it just to go there and also engage in the community, talk with them. We have to put certain things in place that will help bring solution to these problems affect this community. Because if we can't and have the solutions, automatically the situations will still happen there in that particular community. But if we have put certain mechanism in place, I think that it's necessary for us to see how best we can and organize educative learning training for community leaders for them to be part in that particular in training them on certain critical health issue that affecting their community. If I have to, thank you.
So much, Mohammed, for your good question. I think first, before the panelists respond, I would really like us to move with the best language, so that our language does not discriminate. So first of all, it is not people living with HIV and AIDS, it is people living with HIV. And also let's not call them victims. We are not victims. We are just recipients of care. So yes, and let's avoid saying them, those, it's somehow discriminative. So I think we're on the same page. So I don't know how best to pronounce this name, but I'll say Marie because that is the only one I can read well. So Marie, your hand is up. So please, you can go and.
Thank you. My name is Wilson Mary Macau, and I'm from Mozambique. English is not my mother language, but I will try to communicate with you. And I want to, first of all, thank you all the speakers for all your presentation. I do not have a question, but I would like to give my comment about the topic. And I think that it's important to share with you that in Mozambique, we have a limited access to health service, especially in the rural areas. And of course, that this affects children and young mother living with HIV because they cannot take the IRV properly. And of course, that this affects directly in their viral suppression. Personally, I believe in the power of the community, and I would like to highlight the importance to educate and to sensitize the communities about HIV prevention, the stigma, and the rights of people live with HIV, specifically young women and mothers living with HIV. I am the Her Voice Fund ambassador for Mozambique. Is a fund that supports the involvement of AGYW in decision maker space. And through the implementation of the Her Voice Fund, I would like to highlight examples of overcoming and during the treatment because of the community dialogue with AGYW. And I believe that we have to make more dialogues or webinars like these in our country and our communities to combat these issues. Thank you, and over to you.
Thank you so much. Because Macau in Kenya, it's a Kamba name. So yeah, thank you so much for your insights, and I'm really happy and happy. I'm honestly happy to hear the work that you're doing in Mozambique. So I will go on because of time, and then we can let our panelists respond. However, we have Merinjeri who's saying we are losing our clients due to physical practices being cut down. Hence, the organization has been using CHVs, and there's no privacy about it. Hence, this is leading to stigma and denial amongst our clients. Don't know how we can address this issue. Yet the CHVs sent to the community are not HIV positive. This is really unfortunate, Merinjeri. And I am sure, and honestly, I can speak on in the capacity of the Kenya Coordinating Mechanism representative that we are working to ensure that such is not going to happen in the community level. So Irene Choge, hi Irene, I hope you're well. It's been a minute. So Irene has asked a question. Do we have psychosocial support group guidelines for HYW? So I think this is a question that Nadia can respond. And also, do we have strategies in place of sensitization of HYW on U equals U now that you have many cases of despondency among this population? These are really good questions, Irene. Thank you so much. Naira has sent very good documents that I believe, Liz, you can benefit from them. And also, Colin Sogola has said digital component of ARVs dispensed through community-led initiative. Is it there? Wow, this is a good question. This is a really good question. Yes, I think those are basically the questions. So if I will let my panelists, Naira, Cynthia, if you're still there, Joy, to respond to any of the questions that you feel you are best suited to respond. Naira? Are you still here with us?
Miriam, I think our speakers are having issues with the internet, especially Joy. I don't know about the others. And also Jovia has to go off the call because she has another meeting in 1 minute. So for the interest of time, I don't know. I think we shall have to really, I don't know if anyone can answer the question. The rest of the speakers that are on, if they can answer the questions so briefly, as we have only 5 minutes to close our call.
So I think I can respond to what Irene Choke has asked. According to my knowledge, we don't have any psychosocial support group guidelines for HYW, and we also don't have strategies in place for sensitization of HYWs on U equals U. No, we do. To some extent we do. For sensitization on U equals U, this is something that CHEB is spearheading, but not specifically for HYW, but for every other person living and affected with HIV. So this is something that is going to happen, I believe, in the next financial year, in the CHEB financial year, and also psychosocial support group guidelines. I don't think those are things that we have. So this is one call to action that maybe different countries can think through about it, because we really need to have these guidelines. We really need to know how best do we conduct this psychosocial support group to meet the needs of the different typologies that we serve. On Colin Sogola question on the digitization component of ARVs dispense. So I'm aware there's community pharmacies that is going to be rolled out. So this is one thing that you can be on the look for, but it is not necessarily for ARVs. It will be for PrEP and PEP. So this is something that we can start discussions on to ensure that people can receive their ARVs medication at the comfort of their home. So yes, Sharon, please take over from there.
Yes, Miriam, for the interest of time, thank you so much for answering that question. I would really request for all the panelists or all the participants to get to us. You can always ask your questions. We can always be of sorry. We can always answer these questions after here. I would like to know if Liz, if your hand is still up or it is the previous hand, Liz. You can unmute yourself and let me know if you want to say something before we close. Is this a previous hand, Liz? I would take the silence as a no. So people, we are near to closing our call for the interest of time. I know everyone here has other engagements to do. And please, before we close, we would like you to please get to us, ask your questions. We shall always answer. And please, let's get to know each other. Let's advocate. Let's connect. I know we are having people from different countries, from different diversities, from different organizations. Let's connect. I can type my email address here in the chat box for any questions or for anything that you would love to ask. I'll be happy to answer. I'm typing it right now. Yeah, it's there. It's there. So in case of any more questions or to get in touch, we can get in touch with that email address. That's my personal. And also Miriam, you can also give in yours. I don't know if you have. Yeah, good, you have. So before we go, guys, we are going to send in evaluations, and we really urge everyone to evaluate this call. And also before we go, please we are going to put on our cameras for a screenshot. We want to see your faces. We want to see your smiles. Yeah, so can we put on our cameras now? Everyone, can we put on our cameras so that we can take a screenshot before we close our call? Yes, Miriam, I can see that beautiful face.
Hi, Marianne.
Yes,
Hey.
I'm here. I
Hi.
can see you. Yes. This
How are
is
you,
so
Peter?
I'm fine, thank you.
beautiful.
Good to see you here.
Everyone, let's put our cameras.
In 3, 2, make sure you smile. In 3, 2, and 1.
Yay!
Yes. So,
Okay, thank you.
is that fine, Catherine?
Yes, that is okay.
Okay. So thank you everyone for honoring this call. Thank you everyone for being on here to participate with us. We are so happy, and thank you for all the speakers. I know everyone needs to go and but let's keep the conversation going. Let's keep the spirit. Let's advocate for youth and young
Hi
mothers.
everyone, I'm here from Zimbabwe.
Thank you. Say hi to the Babians.
And the international husbands, good day to you. I'm still available. Thank you for the station.
Thank you so much, guys. I'm really happy that you all joined. So, yes, we can end the meeting. Catherine, please end the meeting.
Okay, guys, I think we are going to close our meeting. Let's close our meeting. So, don't forget to fill the evaluations. Bye, everyone.
Bye, everyone.
Bye, everyone. Bye.